Hello, everyone. Good morning, Yitna. Thank you, Don, for a wonderful introduction, and thank you, Dr. Anjali, for the honor of speaking with you. I'm very sorry to be speaking with you from the hotel room across the street, and I just wanted to say sorry for the wonderful colleagues and friends that I see, so many of you at HIPNAT, that I might expose you to COVID-19. If so, I hope that it's no worse than getting a very effective booster for COVID. Um, anyway, so invasive fungal infections are diseases of very profoundly immunosuppressed individuals. So for HIV, it is really at the end spectrum of AIDS with CD4 count, people with CD4 count less than 100. And it has the highest case fatality rate among the OIs. So let's talk about the situation of HIV-related death globally. So UNH and WHO estimate in 2000 we have 1.4 million deaths per year, and by 2020 the target was to get it down to less than a million, which is 50% reduction. But in fact, in 2020 we were at 690 cases that year. So that means there were 200,000 excess deaths that need to be accounted for. We didn't really meet criteria neither for HIV infections nor AIDS-related death. And therefore, the WHO and UNH actually revised their target for 2030 from 0 AIDS to now less than 400,000. And as you know, most of these HIV-related deaths, the majority are from AIDS-related death. The 2020 UNH report, obviously the goal of 90-90-90 translate into 90% of people aware of HIV status, and then 81% total are on ARV and 72% are biologically suppressed. And so how was the world doing at that time? So this is data by the end of 2019 in Sub-Saharan Africa and South and Eastern Africa. As you can see here, the target actually reached pretty well. 87% know the HIV status, 72% are on ARV, and 65% are biologically suppressed. So that's not bad, but not meet criteria. How does that compare to our region of the world? Look at this gap in light yellow. 75% are aware of HIV status, and only 60% of people on ARV, and although, I mean, not of those, but totally only a little more than half are biologically suppressed. So these are estimated by UNH in 2020. Huge gap compared to our African, Sub-Saharan African colleagues. And I think this is very much underestimated. People don't pay attention very much to the Asia-Pacific region. When I sit at WHO guideline, the Asia-Pacific representative is far and few, and a lot of programs to combat advanced HIV disease are pretty much absent in Southeast Asia. So this talk, I hope, to really bring awareness to all of us how important these issues are. So that gaps really translate into a very bad burden of advanced HIV disease in the Asia Pacific. And this map shows the number of people newly diagnosed with HIV in the Asia Pacific with different CD4 counts. So the light yellow show you a CD4 count of less than 200. The darker yellows are CD4 between 200 and 350. And the blue are people above 350. So you could see, and I'm going to help you out because this is difficult to see from the bottom of the hall, is that these are countries with very high prevalence of advanced HIV disease. So Indonesia, more than 50%, Papua New Guinea, the Philippines, as we know, is kind of a late epidemic. And then, strikingly, Thailand and Vietnam were sort of countries, we're here in Thailand, and Thailand is kind of the role model for HIV care here, and it has more than 50% of advanced HIV disease as of the end of 2019, and Vietnam as well. And the orange are the country where the trend, because this is point between 2017 and 2019, Orange is a country where this trend was getting worse. So this is really this is disheartening, isn't it, for the region? And if you look at the overall pandemic in the region, we still have 130,000 deaths per year as of 2020. And that's a lot of death. And as you know, this is very underestimated because lots of people have HIV diagnosed in inpatient or hospital setting have not even been registered, and they've never even get hooked into the HIV system to even be reported. So these numbers are underestimated. So how were we doing in 2021? This is the most updated data. Not much better, and I think 2021, obviously with COVID-19, things are not better. But as you can see, there's even an uptick of both HIV incidents and AIDS-related death. Now, this graph shows you the prevalence of AIDS-associated opportunistic infection and death at the Hospital for Tropical Diseases in Ho Chi Minh City. And this is an old study, but it hasn't changed. And I wanted to highlight that TB made up the majority, about 38%, both confirmed and clinical TB diagnoses, followed by invasive mycosis, about 21%, and cryptococcosis, talomycosis, diagnosed by culture, followed by PCP, 5%. But as you know, there's a lot more PCP than this because this study actually did immunofluorescent diagnostic. And as you know, there's a lot more. We don't do bronchoscopy. We don't do induced sputum in our region very much. And so there's a lot of PCP either missing or not reported in this study. So invasive mycosis is a huge problem, and histoplasmosis is not even considered here because we don't do fungal cultures, blood cultures in the region hardly. So I'll get back to that in a little minute later on in the talk. So what are the challenges in age-associated mycosis? As we know, crypto, histo, and talomycosis are the leading cause of HIV-related death. The diagnosis is really difficult for PJP. It doesn't grow in culture, and as you know, that immunofluorescence is not available, and it's very difficult to get deep bronchial lavage specimen for a good diagnosis. And diagnosis is really protracted for histoplasmosis. It takes about 4 to 6 weeks to grow in cultures, and we don't do that. So we missed histoplasmosis all these years in the region. We thought that doesn't exist. Talomycosis luckily does grow in the regular conventional culture, but it missed a bunch of cases if it doesn't grow in fungal cultures. Antigen detection is available, becoming much more available, and I'll talk about that later in a little bit, but are not yet widely available. Treatments are very limited. You may know that fungal pathogens are eukaryotic. They're not bacteria. In fact, they are very similar, more similar to animals than plants. So it's very difficult to find target that does not target animal. And so treatment options are very limited. As you know, amphotericin B, amphotericin it has lots of toxicity, and azole drugs are not very well absorbed, and it has drug-drug interactions and multiple options. But those are the only drugs we have to treat these mycoses. 5-FC, we talk about very much, is still very hardly available in our region. Fungal opportunistic infections are very neglected globally, and particularly in our Southeast Asia region. Recently, in October of 2022, the WHO came up with a fungal priority pathogen list to guide research, development, and public health action, and include cryptococcosis as a critical priority group, followed by histoplasmosis in the high priority group. And then in the medium priority group, we have PJP and talomycosis, and this kind of depends on multiple factors in terms of the extent of disease, morbidity, mortality, etc. But all 4 HIV-associated mycosis are included in the list of priority of the WHO pathogen list. And so it's important that at least some attention at the global level is now paying attention to these mycoses. I'm going now, each of these fungal pathogens really deserve a talk in itself, but I have this, the next 20 minutes to really give you the highlight of the major advance in talomycosis, crypto, and histoplasmosis, and hope to give you just a tour of highlight of what we've done in the past and what has been done in the last 10 years. So the syndemics of AIDS and thalomycosis in Southeast Asia is really clear, as you could see the epidemiology curve, epidemic curve in Thailand, started in Thailand, in Chiang Mai, particularly in Ho Chi Minh City, and in Guangzhou, southern China. There's a very nice temporal relationship between AIDS and thalomycosis. And I want to draw your attention here to the epidemic curve in southern China, where the number are still going up. And at this single hospital in Guangzhou, number 8 hospital, had 250 cases per year of thalomycosis. And so in this hospital, they had, look at 1,000 people diagnosed with thalomycosis. As you can see, the numbers are still going up over the last few years. So this speaks to both thalomycosis, but also speak to the problem of AIDS in southern China. Guangxi is another province next to Guangzhou. It's really high burden of fungal infections. And this graph shows you data for all patients admitted in their hospital. And they look at 6,000 patients. Of those, 16% were diagnosed with culture-confirmed thalomycosis. And the mortality in blue line here is about 50% by 3 months, compared to about 35% for other infections, including TB and cryptococcal meningitis. So clearly, it's a leading cause of death in this particular part of that country. The global burden of thalomycosis is heavily focused in Southeast Asia. So 99% of cases are from here. So it's really endemic only in Southeast Asia, as we know of. But it has been diagnosed in 33 countries in all continents to date due to migrations and travel. 90% of patients are HIV infected, but we begin to see now an emerging epidemic in non-HIV infected individuals, in people with profound immunosuppression from other causes, and particularly in our region of people with interferon gamma autoantibody that has been described over the last 15 years or so, particularly in Southeast Asian descent. So really interesting disease where thalomycosis is very susceptible to thalomycosis. The majority of patients are male, and that's really just reflects the HIV epidemic. Children can be affected, and we've seen cases of maternal to fetal transmission, so it can be transmitted through blood, and I imagine it can be transmitted through injection drug use. China, Thailand, and Vietnam are the major, the highest burden countries in the region. So a lot of efforts are focused in these 3 countries. And we estimate, based on culture confirmed disease alone, about 18,000 cases and 5,000 deaths. But this is based on culture confirmed, which we know missed a lot of patients. And I wanted to draw your attention. I draw these people. These are, for example, the last year there was 2 cases in Southern California of 2 patients with lung cancers who never traveled to Southeast Asia, developed thalomycosis, and we're in the process of trying to sequence their isolate and see if this is some phenomenon that we worry about with thalomyces being established in the United States and Europe. So there's some animal that also been diagnosed with thalomyces as well, a dog in Brazil and some Egyptian mongoose in Portugal. So there's a concern that the pathogen has spread beyond Southeast Asia, and I would not be surprised. There shouldn't be any problem of a fungal spore travel in somebody's suitcase and go and establish its niche somewhere else. So it's certainly something of concern. In terms of disease spectrum, definitely you get it through inhalation, and I'm sure you develop an acute respiratory illness probably because we don't have a diagnostic here. We don't even think about. It's very similar to coccidioidomycosis, for example, in histo. I'm sure there's an acute component, but in healthy hosts, we don't even know it, or we have a spontaneously resolved infection. We do see localized infection, particularly in the upper and lower respiratory tract in people who are non-HIV immunocompromised patients, and they often involve bone and joint disease. Fungemia is only 40%, and skin lesions only present in about 30% in those patients. But in our patient advanced HIV, we see usually disseminated disease involving the reticular endothelial system, so involving liver, spleen, lymph node, bone marrow, and bloodstream and skin. And there's a triad of fever, cytopenia, hepatosplenomegaly, with high transaminitis and AST-ALT ratio of 2 to 1. Fungemia is about 70%, and skin lesions is present in 50 to 70%. So of course, there's diagnostic challenge in a way that, well, if you have skin lesion, you can make a very quick diagnosis by microscopy, but by the time you develop skin lesion, you've already had it in the bloodstream and dissemination. So that's too late. In a clinical trial we've done in Vietnam, we found that people had a symptom onset for about, going on for up to 6 months, and they come to the hospital multiple times, and diagnosis is missed multiple times until they develop disseminated disease, and that we can culture the blood or clinical specimen. It does take up to 28 days to grow. Previous data from Thailand said up to 14 days, and that was just because we never done fungal culture and keep it for 6 weeks, but now we do. We know that a lot of Thalomyces is missed with the regular blood cultures, or anything less than 2 weeks, you miss a lot of cases. Sensitivity in blood culture is not great, but not terrible, 50 to 70%. And again, it's in late stage. And mortality increased from 20% up to 50% with late diagnosis. So clearly there's a huge need of early diagnosis, antigen detection. So we are very fortunate to be funded by the NIH to develop a tropical medicine research center for thalomycosis in Ho Chi Minh City. And it's a huge collaboration in the entire region, collaborating with Bangkok, with the University of Chiang Mai, with the University of Hong Kong, industry partner to develop a diagnostic pipeline for early diagnosis and perhaps screening, like we have done very successfully for crypto. So we have a PCR assay, we have a commercial ELISA, and we're working on point-of-care diagnostic, which I will talk about in a little bit. So the major assay we have is called MP1P, target a fungal cell protein that is released in abundance in patients with infection in their blood and in the urine. And we can detect the antigen with a monoclonal antibody assay. And this assay was developed by the University of Hong Kong, and collaborating with us, we have optimized the assay and evaluate. We're currently doing a big clinical study, which I'll tell you in a little bit, to validate this assay. And we have commercialized this assay, and a company in Beijing called Thuy Beijing has commercialized it, and it was approved in China in 2020. And here is the result of the validation of the Thuy commercial assay compared to our Duke Hong Kong assay. In 248 culture confirmed thalomycosis and 200 control with advanced HIV disease but no thalomycosis. And as you can see in plasma, the home brew assay, the Thuy assay performed very well differentiate between cases and control. This is our RUC curve, 97%. So that's excellent in terms of able to differentiate between case and control. And that does very well, both in plasma and in urine. So the sensitivity is really excellent here, 96% for both assay, and specificity is excellent between 93% to 96%. And so for an antigen test, that specificity in a very high risk group of patients who can have many fungal infection, TB and other things, is a fantastic specificity. And I want to draw your attention to the fact that sensitivity is superior to blood cultures. So it's done in the same compartment, right, in the blood and urine, and it picks up a lot more disease, and it's much faster. An ELISA takes 6 hours versus up to 28 days. So clearly this is a huge advance that we need to push forward for clinical care. So when you look at the two performance of the in-house and the Thuy, they really overlap, and there's only a couple cases missing here in the Thuy, a couple cases. So very much agree, which we expect because it's the same monoclonal antibody. There's 3 point-of-care antigen tests that is being developed. One by IMI, which is a company that makes the cryptococcal antigen. One by Chiang Mai University right here in Thailand, and one by Duke. And I just wanted to show you some preliminary data of the LFA, the point-of-care lateral flow antigen developed by IMI. As you can see here, the LFA in blue compared to the ELISA in purple, they're very neck to neck here. And when you combine plasma and urine, sensitivity is quite compatible. It's a little lower than the EIA 91 versus 95, but that is expected. LFA will not beat EIA in terms of sensitivity. And you could see plasma perform a little less well, 81% compared to urine, 88. So urine is a fantastic specimen. And so that's really great because you don't need to do a blood draw really. And you can pick up a lot of cases. And the key here is that it's much more sensitive than blood cultures. So this is really exciting because what it means is that we can use the LFA to screen for disease in the community, much like we've done for cryptococcal meningitis. The model that worked very well here is a cryptococcal meningitis where, you could screen for antigen before it disseminates to cause meningitis, and you can pick up antigen in the blood of patients 22 days, and that's average. They can pick it up between 5 and 234 days before meningitis. If we can do that, we can really modulate the natural history of the disease by screen, detect, and treat, versus giving everybody itraconazole like a primary prophylaxis. So very quickly, cryptococcal antigen screen and treat strategy has been shown in a randomized trial published in the Lancet in 2015 to show a mortality reduction here of 28%. So clearly there's evidence of not just, reducing incident, but actually mortality. And this is a very recent paper published by David Bower group, where they screen for antigenemia in people who are symptomatic in clinic with an antigen test and refer them to the hospital for LP, and just simple act of actually screening people, symptomatic people, the mortality reduction here, as you can see, about 25% by week 10. So there's benefit both in asymptomatic, as you could see before, and with this slide, clearly even symptomatic people, screening help. And so we try to do the same thing. We try to, I think in our region is the only region we can coin the term triple fungal screening, because we have all fungal pathogen here in this region, not just crypto. In the WHO guideline, they only focus on crypto. We have crypto, we have Thalomyces, we have histo in this region. And so we can really kill 3 birds with 1 stone and really impact care dramatically. And so this study funded by the NIH and also the National Institute for Health Research from the UK is where we screen people with advanced HIV disease and with 3 antigen tests for histo, crypto, and Thalomyces, alongside with intensive TB screening program. So we did export directly from blood and urine of patient, and we did microlytic culture and keep for 6 weeks to diagnose these major pathogens that I mentioned. And then, in people with TB and crypto and histo, we treat right away, provide early treatment. But in Thalomyces, because the diagnostic is still being evaluated, we closely follow patients until they develop actually culture-confirmed disease and provide treatment. And the idea is to prevent disease from developing and mortality. And here's a study where we enroll a total of 900 patients with just complete enrollment and soon to complete follow-up, where we did this intensive method of screening on everybody coming to the hospital with low CD4 count of less than 100, regardless of what symptom they have. We did mycobacteria screening as well, as I mentioned, and we follow people monthly over 6 months to really understand what antigenemia means. What we found here is a huge burden of telomycosis of 19%, about 4% with crypto, 4% with histo, and this is significant. And as you expect, 27%, these are microbiology confirmed tuberculosis. And of those who are not TB, the majority of them, well, the vast majority of them are MAC. So it's I don't have time to go into the detail of this study, but as you can see in this pie chart, that TB and invasive mycosis, I'm not even counting PJP at this time, is more than 50% of the pie. And this is really tremendous disease burden. In outpatient, we have a cohort of 500 who just finished recruitment, and we're going to follow up for 12 months. The prevalence is similar but less. So 8% telomycosis, 4% crypto, 2% histo, and 7% TB, and then 1% MAC. Again, it's make up total 20% of asymptomatic people in clinic. So this is significant. I have a few minutes left here to talk about treatment, and I'm going to go very fast. Sorry about that. This is a trial that we did in Vietnam and a while ago now. But really, the first clinical trial for treatment of thalomycosis, as you could see, amphotericin B reduced mortality significantly, 50% reduction in mortality by 6 months, which is remarkable compared to itraconazole, which we use more frequently in Vietnam, 70% of the time. So that's a significant difference in saving lives since we've done this study. And you can see the fungal clearance dynamics here with amphotericin B in the blood. It's actually clear the fungus 4 times faster than itraconazole. But amphotericin B is highly effective, as you could see, but it's toxic. So there's a balance to play with infusion-related reaction, as you know, kidney problem, electrolyte abnormality, and toxicity accumulate. And so the question here is, does less equal more? And so I wanted to very quickly go through, ask the question, is shorter course of ampho-B as effective as 2 weeks of therapy? And the second question is a single dose liposomal ampho-B as good as 2 weeks of amphotericin B? And this is data from cryptococcal meningitis, the ACTA trial published in 2017 in the New England Journal of Medicine. This is multi-center study, 800 patients. And as you can see on the left here, mortality are no different between the 1 week of ampho-B plus flucytosine versus 2 weeks of ampho-B and flucytosine, and also fluconazole and flucytosine. So there's no difference in mortality. They've also done fungal clearance in the CSF, and it looks similar as well. On the right here, I want to draw your attention to when they look at the backbone of people treated with ampho-B plus fluconazole versus ampho-B plus flucytosine. As you can see, mortality is significantly lower, 31% versus 45% in people treated with ampho-B plus fluconazole. So flucytosine is a very important accompanying drug to amphotericin B. There's in vitro data that actually inform these clinical trials. So flucytosine is I want to stress, a very important secondary drug, not secondary, adjunctive drug to ampho-B when you treat these fungal infections, when you treat cryptococcal meningitis. This is a study done right here in Thailand. It's a multi-center run by Dr. Methe from Mahidol University in 12 different centers here across Thailand. It's a nice study done. They're comparing 1 week versus 2 weeks of amphotericin B in Thai people. And as you could see, mortalities are very similar. There's no difference at week 10 between 1 week versus 2 weeks. So again, confirm the results of the ACTA trial. What about single liposomal ampho-B? This is a study that many of you may be familiar with called Ambition trial, published in the New England in, I believe, June of 2023. So very recently, comparing single dose liposomal ampho-B plus 5-FC plus fluconazole compared to 1 week or 2 weeks of deoxycholate ampho-B and 5-FC. And so that's very bold because single liposomal ampho-B has been used in leishmaniasis and it has been shown to be safe, well tolerated, and they wanted to see. And what they found is, again, it's very similar mortality. If anything, there's a 4% absolute reduction in mortality in one single dose of embrazone compared to 1 or 2 weeks of deoxycholate ampho-B. And the fungal clearance dynamics in the CSF are exactly similar. So that's really great news that you can give less amphotericin B, achieve the same effect, and less side effect. As you can see here, the side effect of grade 3 or 4 event is much lower in the single dose arm. So the WHO kind of took this on and really do a rapid advice for now being a preferred regimen in resource limited setting. And the US and European guidelines also follow, not the preferred, but as an option. I don't have any more time, but I'm going to very quickly talk about a histo trial that was published just a few months ago of single dose liposome ampho-B for histoplasmosis in 6 different centers across Brazil, and they found very similar things. So our next question is, and this is my next to last slide, is that can this be single dose embrazone and the 5-FC idea, can it be used for thalomycosis as well? And we found in our lab that ampho-B and 5-FC has synergistic activity. As you could see, the MIC reduced more than 4-fold here for both N4B and 5FC, so it's bidirectional synergy. And so that's really compelling for us to move forward to a clinical trial testing single dose liposomal N4B compared to 2 weeks of deoxycholate with a lot of toxicity. So that would really improve toxicity for patient, and perhaps it's going to be a factorial randomized trial where we add 5FC and 5FC placebo to see if that even improve mortality further. So what's the take-home message here? Epidemiology, we have very high prevalence of advanced HIV disease in Southeast Asia, and invasive fungal infection make up 25% at least of all OIs at very high mortality. Diagnosis, antigen detection provide a rapid routine diagnostic. It can detect disease up to weeks before overt disease. Urine is an excellent sample for testing for chylomicrosis, as the case for histo. And combined urine and serum is improved for sensitivity. For treatment, N4B induction save life, we know that. And single-dose liposomal N4B is as effective and has better safety profile compared to a prolonged 1 or 2 weeks of N4-TSMB. So this is really a coming sort of theme. And 5FC combination therapy, potentially, it has already been shown to save life in cryptococcal meningitis and should be tested in chylomicrosis and histoplasmosis. And finally, I think really important to think about in our region, working together, particularly Thailand, Vietnam, and China, to work on a triple fungal screening program, screen and treat strategy, I think will really make a dent in bringing the number of AIDS deaths down in our region. So I thank you so much for your attention.
Okay.